Good afternoon. It's my privilege to welcome Dr. Shrinath Pratap. He is from Department of Endocrinology and he has 14 publications in national and international journal, and his areas of interest are pituitary and metabolic bone disease. And he will be talking on the topic practical approach to hyponatremia. We come across hyponatremia. It is the most common electrolyte imbalance we see with the multifactorial etiologies. So sir will be giving us insights on this topic which will help us in our daily practice. Over to you, sir.
Thank you for the kind introduction. So I'll be directly going to my topic. It's a practical approach to hyponatremia. So the learning objective will be learning how many types of hyponatremias are there, what are the diagnostic strategies that are important, treatment and complication prevention. So any sodium less than 135 qualifies as hyponatremia, but we are worried usually when the sodium is less than 130. So between 130 to 135 we are having a conservative approach. And hyponatremia is common in OPD practice, but it's much more common in inpatients. So inpatients can have infections, they can have hypervolemia, hypovolemia. So a lot of references come for hyponatremia. How renal parameters can vary, your sodium can also vary. So etiology, it's basically vasopressin mediated. You can have increased vasopressin where there is no feedback inhibition, increased sensitivity to vasopressin, increased free water intake, increased solute loss. Implications, it increases the morbidity and mortality of during the admissions. It also increases the length of stay. So a lot of times we have admitted patients for hyponatremia, given 3% saline, we wait till sodium is better and then discharge. But now with Vaptans we are able to manage in OPD also. The other thing is to avoid complications. We have to treat, but we have to avoid complications. So whenever a patient comes to you, one of the key feature is you want to know the severity. Is the patient very sick or is the patient mildly symptomatic? And what's the timeline? Is it quick, last 48 hours, or it's been there for a long time? Like in CLD we see that a lot of patients have hyponatremia for a long time. Then what's the volume status? So volume status, you have two options. One is you can look at clinically evaluate pedal edema, basal crepitations, JVP, and also in ICU you can have central venous pressure. Then medical contribution. So a lot of times thiazide diuretics could be a contributory feature. It could be antidepressant, antipsychotics which are contributory to the admission. So coming to the first severity, so you can have mild symptomatic hypoglycemia, moderate symptomatic. So usually 125 to 130 people are mildly symptomatic. When sodium starts becoming below 120, that's when they become severe. And if you look at very low sodiums, 100, 110, they can have they be altered sensorium, seizures and coma. So then coming to developmental timeline, so this is approximate 48 hours. So anything less than 48 hours is acute hyponatremia, anything more than 48 hours is chronic. The division here, the most reason is when it comes to treatment, chronic hyponatremia you can be relaxed, take it very slow, you do not have to aggressively correct it. Acute hyponatremia you have to correct it early so that you avoid complications. Then coming to volume status, so volume is a clinical decision as I said. So based on the volume you have three etiologies: hypovolemic, euvolemic and hypervolemic. So hypovolemic is usually due to both sodium and water loss, but the solute loss would be more in these conditions. Euvolemic is what we commonly diagnose in the hospital setup, SIDH. So syndrome of inappropriate diabetes insipidus. So this is little overdiagnosed. So a lot of times we miss hypothyroidism, we miss hypocortisolemia, we miss drug induced, branding it as SIDH. So that's what I am going to talk today. And then you have hypervolemic. Patients with congestive cardiac failure, CLD, CKD can have higher water retention compared to sodium, and that's where you see hypervolemic hyponatremia. Then you have finally pseudo hyponatremia, which is more of you have to look at the lab parameters, look at the background and diagnose. So, comprehensive approach, first is the history, examination, then look at the lab parameters. When you ask for lab sodium, you are going to definitely ask, but along with that ask for other electrolytes, bicarb. Urine sodium is very important. So, if the urine sodium is low, then you are looking at depletional hyponatremia, and you should usually send the urine sodium before you start the sodium correction. If you do it after sodium correction, it will be high. Then serum osmolality. So, normally in SIDH your urine osmolality will be high. So, you expect a dilute urine. Then you have cortisol and thyroid profile which has to be done. Then endocrine testing is very important. So, lot of time we send the thyroid profile, but we fail to check the cortisol. So, coming to hypovolemic, so most common hypovolemic hyponatremias are GI, that is vomiting, diarrhea, diuretics, third space loss, burns, and also it could be extra renal. So, how do you decide whether it is renal or extra renal is based on the urine sodium. Then you have euvolemic, which is the most common causes of hyponatremia, but frequently overdiagnosed. So, you can have SIDH due to malignancy, which is associated with weight loss usually, then CNS disorders, drugs. So, urine sodium will be typically more than 30 in these cases, and you have to rule out endocrine disorders. Coming to hypervolemic, so as I told, the most common disorders are heart failure, cirrhosis, nephrotic syndrome, renal failure, and these patients typically have sodium urine sodium less than 20. So, this is a brief overview. First you have to decide based on the clinical whether it is hypovolemia, euvolemia and hypervolemia. In euvolemic patients you have to see the urine sodium which is more or less, and you decide based on that. Coming to general principles of management, so treatment should be individualized. You do not have to treat every hyponatremia, and you do not have to give everyone 3% saline or tolvaptan. So, you have to also prevent overcorrection. So, usually the normal way to correct is first 6 hours you have to not correct more than 4 to 6 millimoles, and over 24 hours not more than 10 millimoles. And close monitoring is required. You have to repeat sodium at least twice or thrice a day, and when the patient is better or you have overcorrected, you have to go slowly. So, in an acute setting you have to give a trial of saline. So, any hyponatremia, you first give saline and see whether it responds, and failure to respond, because many of them are depletional, and then you have to start treating with 3% saline if required. So, normal what we do in here is we give it a 10 ml per hour rate, but if you look at guidelines, they all recommend give it in the next half an hour or 20 minutes. So, you target around 4 to 6 millimole increase in the first 6 hours and then 10 millimoles over the next 24 hours. In chronic asymptomatic hyponatremia, you have to limit corrections to less than 8 millimoles in 24 hours. You can go easy, you can give water restriction, extra salt in the diet, and if this does not help, you can go with tolvaptan or 3% saline only if required. I will discuss some cases to keep it interesting. So, 65-year-old lady who had a fall at home, brought to ER, found to have subarachnoid hemorrhage, and admitted under neurosurgery subsequently. During admission, patient was little drowsy, sodium was 125. So, this is the MRI. It shows both hematoma, subdural hemorrhage and subarachnoid hemorrhage. So, during the hospitalization, for the low sodium and drowsiness, started on 3% saline, and there was no improvement in the sodium. So, if you see in the next 48 hours, sodium still remains the same around 121, and now the patient is receiving 30 ml per hour continuously for last one day. Investigations, the urine osmolality was high, sodium spot was high, so that's a repeat. So, what next? So, what would you do? What would you think of in this patient? So, in these patients you have to look at the input output and volume status. So, this patient had a mild dehydration, input was less than the output. So, we thought of cerebral salt wasting and we asked for NT-proBNP. So this patient had cerebral salt wasting, which was not responding to the traditional, how we treat SIDH. So what is the treatment of choice here? So usually the treatment of choice is fludrocort, and you have to also make sure you match the input and output. Next patient is a 65-year-old lady who has sodium of 118, has confusion, and she's symptomatic past 3 days, so she comes in the chronic category. She is euvolemic, so she is on SSRI, and what's the plan here? Stop the drug and extra salt, and since the sodium was very low, you could admit and give tolvaptan or 3% saline. So management of hypovolemic, which is the most common, is depending on how bad is the sodium. You can initially treat with normal saline and address underlying cause, and then finally treat. So this I told you. Yeah, third patient, a 44-year-old gentleman who comes to an emergency department with seizures and loss of consciousness. Again, sodium is low, urine spot sodium is high, treated as SIDH, and subsequently improved and discharged. Now readmitted after 4 months. So again sodium is low, but this time a cortisol and thyroid profile also was sent. So what do you see in the cortisol? So normally whenever you have hyponatremia, your cortisol should be high, so it should be around 18-20. So here it's only 3. So this patient had adrenal insufficiency, and if you look at the free T4, it's low. So something central, so not primary hypo, central hypothyroidism along with cortisol. So it localizes to pituitary. So that's when they did for assess the other pituitary axis, and if you see all axes were involved. So this is the MRI. So MRI showed a pituitary macroadenoma, and that was causing hypopituitarism and hyponatremia. So your revised diagnosis is pituitary macroadenoma. So a lot of times these are missed. So similarly we had one more lady, she was symptomatic from last 5 years, and her main problem was hypoglycemia, not altered sensorium, and during admission sodium again was low. So evaluated, again the pituitary hormones were low. This was a lady, and when we asked additional information, that's a menstrual history, she said she had amenorrhea since 4th pregnancy, and further questioning, no lactation, history of blood transfusion. So answer is straightforward, she has. So this was missed basically because no one asked about menstrual history. So this was her MRI, you had an empty cell. So then coming to management of hypervolemic hypovolemia. So here main thing is water restriction. You can use diuretics, use Vaptan selectively, and treat the underlying condition like heart failure or what is causing. So Vaptans have changed the way we look at hyponatremia, especially now we can manage patients in OPD basis. They inhibit the renal water reabsorption and used for refractory euvolemic and hypervolemic hyponatremia. Only problem is cost and liver toxicity, and data is not there for long term use. So most of the data is for 3-6 months. So though we are using for longer duration here, that's not there. Finally coming to osmotic demyelination, so this should not happen. So I have a patient who had this in Bangalore. So we should not overcorrect hyponatremia. So go slow, and if you have overcorrected, please also add 5% dextrose or dextrose normal saline. Stop correction, go slow. So how to manage overcorrection? This is what is shown here. So common pitfalls is lab testing. Some labs, I had one patient who came from Udupi. Always potassium sodium would be low, and I had no explanation. So when I repeated here, everything was normal. Patient was receiving tolvaptan for that. And you have to look at the medication list. Though if you Google, there are a lot of medications which can cause hyponatremia. There are drugs which are not mentioned and can cause hyponatremia. So you have to look. I have a patient who has hyponatremia zolpidem, which should not cause hyponatremia. So all these things you have to take care. And there is something called endurance athlete having hyponatremia. So these endurance athletes, they tend to have hyponatremia after physical bout. This is because when they sweat, they sweat solute and water, but the fluid that they're taking is more water and less in solute. So post this thing you can have. Then you have beer potomania. So these are one of the final cases. So this is a true patient again, a 55-year-old gentleman came with generalized weakness and diabetes. He knew, but he was not on medications, a typical Mangalore patient, and RBS was 455, sodium was 125. So that's where I was called. So before I went, the patient was already on 3% saline. So how many would say that this patient needed a 3% saline? Correct. So ideally these patients you should look at the corrected sodium. So this is the corrected sodium value. For every 100 milligram rice you should correct it by 1.6, and so the corrected sodium here was around 130, still hyponatremia but didn't need 3% saline. So actually our neurologists were worried that this patient was weak because of central demyelination syndrome, but subsequently he improved. It was not that bad, because 125 to 136 was crossing the 10, so they thought the intern had overcorrected, but actually he had not overcorrected. So key takeaways: confirm hyponatremia, look at the volume status, decide the emergency of treatment based on the symptoms, and don't be overzealous in correcting. Especially 3% saline, I think we should use it more cautiously because it is difficult to titrate. Vaptans would be more better only when they don't respond or it's an emergency situations you can use 3% saline. In fact, I think UK, my one friend was working, they're almost banned from using 3% saline. So they need special permission for that. Thank you.
So like if the patient comes with the sodium of 105 and we start correction 3% saline and after maybe 12 hours it's more than 10, still the patient is in altered sensorium.
So that's a difficult choice. You also have to look into other causes for altered sensorium. So many of these 100s, 110 have adrenal insufficiency also. So you have to look at the adrenal axis. So usually our target though is 10. You have to go slow.
So that's right. In that situation, we need to stop or we can continue.
You
if the patient is
go slow, still stop. Yeah.
Reduce the.
Yeah. And one more thing to note is how acute was it. So sometimes we get chemotherapy induced hyponatremia. So cisplatin can cause renal sodium loss and hyponatremia. So that's very short duration. So yesterday patient sodium was 136, today it's 110. So those patients you can correct faster because the risk of osmotic demyelination is not there. But general patient who has been sick for long, still you go slow.
Thank you, sir, for the wonderful presentation. You kept us awake by telling us the various case scenarios.
Thank you.